to a neurodiversity affirming approach to working with eating disorders in adolescents and adults. I will begin with an acknowledgement of country. This training was developed on Turrbal and Yagara land in Brisbane, Australia. My name is Lucy. I am an eating disorder credentialed psychologist, and I have experience working with eating disorders from 2010. My primary experience was working on an inpatient, came through working on an inpatient team on an eating disorder program, and I've also have experience running an outpatient eating disorder program in a psychiatric hospital for many years. And I've worked with eating disorders in a private practice setting from 2012. And I'm also one of the two directors at Exhale Psychology Centre, which is a private practice in Brisbane that works with primarily eating disorders, neurodivergence, complex trauma, treatment-resistant depression, and other similar complex issues. And on a personal note, I'm the mum of an ADHDer with ARFID. So I'll just take you through an outline as part of the introduction. So Module 1, Week 1, will look at a much needed paradigm shift. So we'll be doing that today and looking at what this looks like in practice. Module 2 will be looking at safety, which is an acronym for a neurodiversity affirming approach to developing neutral food relationships. So this is a modification of the RAVES tool for eating disorders that specifically targets neurodivergent folks or those with a strong sensory palate. Module 3, Week 3, will be looking at supporting clients to untangle their neurotype from their eating disorder. Module 4, we'll be looking at working with ADHDers with eating disorders and eating differences. And Week 5, Module 5, with autistic clients with eating disorders and eating differences. And throughout both of those topics, also looking at ADHDers, so those that are autistic and also ADHDers. Module 6 will be considering the evidence-based treatments for eating disorders. So we'll be breaking down the approved eating disorder therapies as per Medicare's eating disorder plan. And even for dietitians, I think, or other health professionals, it is really important to complete that module as well, so you can understand what is being delivered and how it may and may not be neuroaffirming. Module 7 is a lived experience presentation with Jackie Harvey, and there's also an interview with Jackie there too. Module 8, Week 8, is working with high-risk clients and using a harm reduction approach. Module 9 is working with complex trauma and other complex presenting issues. And last week, Module 10 is navigating client ambivalence and dishonesty, and also takes a look at navigating non-affirming health practitioners' stakeholders. So I'll just introduce you to our guest speakers. So Andrea is doing Module 4 and 5. Andrea is a dietitian, a colleague of mine. She is a lead identified ADHDer, and she's an eating disorder credentialed dietitian with over 10 years experience. And Module 7 is presented by Jackie, also a colleague of mine. Jackie is a late identified ADHDer, and Jackie has lived experience of an eating disorder and is a psychologist working in the area of neurodivergence and eating disorders. Introduction. So why do we need a neurodiversity affirming approach to working with eating disorders? Feeding and eating disorders are significantly overrepresented in the neurodivergent community, so roughly 1/3. And the treatments that we do have are not effective for neurodivergent folks and have been shown to cause harm. And currently there is no evidence-based treatment for ARFID. So throughout this training, we'll be breaking that down in more detail and looking at the evidence for that, and also considering the lived experience perspectives. Potential issues with standard psychotherapy and its application to neurodivergent individuals. So, Dr. Alice Nichols, an autistic psychologist, has pointed out that traditional therapy is often not a fit for neurodivergent individuals due to the therapy relying on clients being able to recognize and report mood. So, it's estimated that approximately 50% of autistic adults have alexithymia. The therapeutic goals are often not appropriate and not in line with the client's goals. Autistic burnout is not recognized as part of the therapy. The therapy requires the client to take a different perspective. The therapy relies on cognitive challenging. The therapist uses a neurotypical communication style. The social demands of the sessions can be too high, and the client is expected to have a neurotypical rate of change. So even before we even begin to look at eating disorders, we can see some issues with our current treatment, our current communication styles in delivering that treatment as potentially not being a good fit for neurodivergent folks. All right, those are the references for those previous slides. So how have I come to develop a neuroaffirming approach to working with eating disorders? Well, I want to be transparent in that it was a very slow process. I started off working, as I said before, in an inpatient psychiatric facility, and this hospital was not neurodiversity informed nor affirming. The medical model we used was very weight focused and non-individualized, and the inpatient model was like a revolving door where we'd see clients come in, re-nourish, discharge, only to come back in again in a few months. And it was clear that it was leading to significant distress for many neurodivergents and neurotypicals alike. In terms of the treatments of eating disorders, the medical model was not working for the vast majority of the inpatients we saw. The idea behind this training actually came from years of my neurodivergent clients reporting to me that the current eating disorder therapies are not working for them and me trying to adapt along the way accordingly. And this included inpatient, outpatient programs, and healthcare providers, with clients reporting that it just wasn't helping them and leading to a lot of frustration and feeling misunderstood. So this training is primarily based on what they report is helpful or unhelpful, or really aims to take that into consideration every step of the way. And together with my clients' experiences, the training also draws from other neurodivergent folk with lived experience of an eating disorder, including colleagues and activists, and I reference the work of these people throughout the training. Assumed knowledge. So this training is not an introduction to neuroaffirming practice. If you are new to neuroaffirming practice, this is definitely not the place to go. There are many good resources out there, but I'll just break down a few of the very, very basic elements of a neurodiversity affirming practice. So it is assumed that you as a clinician will be aware of the neurodiversity paradigm. So this is a term coined by Nick Walker, and it posits that neurodiversity, in particular autism and ADHD, are not a deficit, but are a result of natural biological variation. So according to the model, neurotypical brains are not the standard and neurodivergent brains are not a deficit, but that each has their strengths and difficulties. I'm aware that the term neurodivergent covers a range of neurotypes, but for the purposes of this training, I'm focusing specifically about autism, ADHD and ADHD. It is also assumed that clinicians will be using neuroaffirming language. So for example, that's identity first language. So clinicians will sort of be trained to use person first language when they're discussing an illness. So for example, we don't say anorexic, we say someone with anorexia or someone with restrictive eating. But as ADHD and autism are not an illness to be treated, but a part of the person as per the neurodiversity paradigm, we use identity first language, such as autistic person, not person with autism. This can be quite a learning curve for clinicians that are really used for person first language, but it does get easier with time. I think it is also important to say that some neurodivergent individuals do prefer the person first language, but the general preference is for identity first. But you can always check with that particular client if uncertain. We also don't say ASD or autistic spectrum disorder because it's a difference, not a disorder. It's expected that clinicians will be aware of the social model of disability. So the medical model of disability defines a disabled person based on their limitations. That is, the problem lies with the individual's impairment. Whereas in contrast, the social model of disability sees the challenges of living with a disability as primarily the result of people with various needs and abilities living in a world that is built for one kind of ability only. So in the words of Mike Oliver, a sociologist that is very active is an activist in this area, the problem isn't that I can't get into a lecture theatre, the problem is that the lecture theatre isn't accessible to me. I'll also touch on the double empathy problem. So double empathy theory argues that social difficulties are not specific to autism and that problems arise from a mismatch in perspective between autistic and non-autistic people. And this is now supported by evidence. So according to the theory, these are communication differences that arise out of biological variation, and no one communication style is superior. So it's not like neurotypical people communicate effectively and neurodivergent people communicate, or autistic people communicate wrong and differently. We both have different communication styles, each with its own strengths and difficulties. It's assumed that clinicians will be aware of making sensory accommodations in the therapy space. As per the social disability model, we do see that therapy spaces, just like other spaces, are really built for a particular type of person or a particular type of accessibility. So this might mean making changes based on lighting, temperature, sensory tools, and Andrea will break this down in more detail in modules 4 and 5. It's also important to be aware of spoon theory. So this is a metaphor initially developed in the context of chronic physical illness, but is now also commonly used in the neurodivergent community to refer to someone with limited resources that may vary day to day. In terms of why it's spoons, it doesn't really seem to be a reason for that, other than just spoons are a metaphor for battery usage or energy usage. Rejection sensitive dysphoria. So in terms of neurodivergence, this refers to repeated experiences of invalidation from health professionals and neurotypicals to the point that the individual has accumulated distress or trauma from a chronic pattern of being misunderstood. And it's also really important that anyone working in this space is actively led by the neurodivergent community. So it is not up to neurotypicals to decide what is neuroaffirming. It is up to neurodivergents, and that can vary from person to person. And it's also important to highlight that the DSM does not reflect our current understanding of neurodivergence and its presentation. If you are new to neurodiversity affirming practice, or if this is something you could use a refresher on or learn more about, I strongly recommend looking into training and work done by Marie Kamen, Esther Fiddick, and Michelle Livock. And there's many others, but there's some good places to start. All right, assumed knowledge in terms of working with eating disorders. So it is assumed that you will have basic competency in terms of working with eating disorders. This is not an introductory training to working with eating disorders. So some common areas I would expect people to have understanding around, and if you don't, that's definitely something to look into, is being aware of the general eating disorder diagnoses and the appropriate treatment. The transdiagnostic approach to eating disorders by Christopher Fairburn. So this is the idea that various eating disorders such as anorexia, bulimia, binge eating disorder, etc., generally have the same maintaining processes such as body image disturbance and low self-esteem, and that this is different or distinct from ARFID, pica, and rumination disorder, which are fundamentally different. It's expected that clinicians will have a basic understanding of evidence-based treatment for eating disorders, although we will break down each evidence-based treatment for eating disorders in quite depth in Module 6. It's expected that clinicians will have an understanding of starvation syndrome. So this is the physical changes such as poor circulation, emotional changes such as irritability, social changes such as social withdrawal, changes in cognition such as concentration difficulties, and changes in attitudes and behaviors relating to food and eating. And this all occurs in the context of chronic restricted intake. Clinicians should definitely be aware of refeeding syndrome. So these are the health risks associated with increasing intake after a long period of restricting. So that's a common a gap of knowledge where clinicians are presented with a client who is eating very little or has eaten very little for a long time, and they think, oh, getting them eating as much as possible, as quickly as possible is helpful, but that is not the case. That can be quite dangerous. And it's also expected that clinicians will have an understanding of the RAVES model by Shane Jeffrey, the dietitian. So this is an approach to nutrition that has building blocks. So it's an acronym where each letter builds on the other. So regularity, adequacy, variety, eating socially and spontaneously, although we will talk about this in Module 2. And it's also expected that clinicians will generally understand the common medical complications associated with eating disorders, such as postural tachycardia, electrolyte imbalance, and gastrointestinal issues. But if you are new to eating disorders, or you need a refresher on this, or want to make sure you are aware of the basics, the Centre of Excellence in Eating Disorders, so CEDE with a C, and Eating Disorders Victoria offer a lot of introductory training to working with eating disorders. And they also have a lot of free training, so they're definitely worth looking at. And at the Excel Psychology Centre website, there's also resources and blog articles on frequently asked questions about eating disorders, that kind of thing. All right, so affirming practice. So from my perspective, affirming practice means a lot more than just neurodiversity affirming. An affirming practice should also include weight neutral, a weight inclusive practice. This is because less than 6% of people with eating disorders are underweight. So we need to not assume that clients with eating disorders are underweight. And it's really essential for many of our clients that we're fat positive and weight neutral. Affirming practice will also mean being queer affirming. So that means using preferred pronouns, not assuming heteronormativity or cisgender, etc. And up to 70% of autistic people identify as non-heterosexual. Autistic individuals and ADHDers are up to 7 times more likely to identify as trans or gender non-binary. So if you're going to be working in a neurodiversity affirming space, it is also essential that you are queer affirming as well. Trauma-informed. So one study found that 72% of autistic adults have experienced interpersonal trauma, with 44% meeting the diagnostic criteria for PTSD. So this means, and we'll go more in the later models at what a trauma-informed approach actually looks like, but just not assuming that clients don't have trauma, or not thinking that they need to have a PTSD diagnosis to have trauma. So we want to really have that in mind for all of our clients, that there may be trauma either identified or unidentified. And one other important aspect of affirming practice is just generally being intersectional. So neurodivergent folks are often part of marginalized groups. They're more likely to be queer, more likely to have trauma, but other areas too. So for example, neurodivergent folks experience high rates of co-occurring health concerns and chronic health conditions such as hypermobile Ehlers-Danlos syndrome, HEDS, and postural tachycardia syndrome, POTS. So we need to be mindful that our clients in this space are likely to be marginalized in a number of different ways. This training aims to support clinicians working with clients with various sensory preferences and aversions, and it may not always be due to neurotype. So one reason can be due to neurotype, but we might also have clients with sensory processing disorder. So there is controversy around whether that exists. It's not acknowledged in the DSM, but nevertheless is used to describe strong sensory preferences and aversions that are not linked to neurotype. We can also have sensory differences in clients with trauma. So, for example, in cases of sexual abuse, this can include foods with certain mouthfeel. Clients might have very differing sensory needs due to having obsessive compulsive disorder. So for example, I have a client that identifies as neurotypical, but she has OCD, and one of her OCD challenges is difficulties is eating food that comes in bright colored packaging. We'll also have clients with obsessive compulsive personality disorder. So there is a debate in the field at the moment of whether OCPD is just autism in females. But clients presenting with OCPD will have a really strong need for things to be visually ordered, for example. And we'll also have clients with biological differences other than neurotype. So for example, we might have clients being born with large pupils resulting in light sensitivity. So defining eating differences and distinguishing them from eating difficulties versus an eating disorder. So I could not find a definition of these, so I created my own. So this is how I conceptualize the differences. And based on these definitions, ARFID is not an eating disorder, but an eating difficulty. And this is not intended to minimize the severity or the distress that can be associated with ARFID. So I've defined eating differences as feeding and eating behaviors related to neurotype or sensory preferences. These behaviors may not fit into a neurotypical idea of normal, but do not cause distress to the individual or result in nutritional difficulties. In contrast, eating difficulties is where feeding and eating behaviors related to neurotype or sensory preferences do result in difficulties for the individual in terms of their mental health, such as stress, or physical health, such as low iron. Disordered eating is feeding and eating behaviors that are not due to neurotype or sensory preferences and are not aligned with the individual's true preferences and that cause mental health difficulties or physical health difficulties. And I've defined eating disorder as a consistent pattern of feeding and eating behaviors or feeding or eating behaviors that are not due to neurotype or sensory preferences, are not in line with the individual's true preferences, and that cause mental health difficulties or physical health difficulties. So there's the references for the previous slides. And that concludes the introduction. Module 1, a much needed paradigm shift. So I want to begin by acknowledging that I'm aware that this page and the following slides are quite controversial. I am extremely appreciative of the people that have spent the time to develop eating disorder therapies, and I'm also extremely appreciative of those who have taken the time to research them. The expression comes to mind that we are standing on the shoulder of giants. We all have the same goal. We all want to help people recover from eating disorders. We all want to help accommodate those with sensory difficulties. And essentially, one thing we have in common is we really want to reduce suffering, whatever way that might look like. So I'm going on to criticize the eating disorder field, or I guess acknowledge its limitations. And this criticism really includes myself as someone who worked for years in a hospital setting and who also needs to continually adapt and reflect and do better. However, it is really important that we are able to acknowledge that we need to do better. The rate of relapse is around 50% for eating disorders, and keep in mind that the research we have generally excludes people with complex co-occurring issues. It excludes clients that are identified as pre-contemplative, and the dropout rates is pretty high. So with some of our studies, the dropout rates for treatment is 50%. So we definitely need to improve our practice. So current eating disorder treatment and much of the research works from a compliance-based model. And throughout the following modules, we'll really talk about the issues with that and how it is really distressing for clients, and clients are being very, very vocal that they want something different. And it creates a patient-therapist hierarchy where the therapist always knows best. Unfortunately, this has resulted in a very punitive approach in a lot of spaces. And this is particularly problematic for PDAs, those with persistent desire for autonomy. And it can reward masking and over control presentations and punish under control presentations. It can be re-traumatizing for clients with developmental trauma who have had negative experiences with authority figures and have difficulty trusting others. The current approach tends to blame the client for not being able to recover and often uses labels in practice such as pre-contemplative, non-compliant, and treatment resistant. We really need to move away from the idea that motivational issues are the client's problem rather than a part of the presentation that we need to work with and support. Current eating disorder treatment uses a very traditional exposure therapy framework. Neurodivergent individuals cannot thought challenge or behavior experiment their way out of their neurodivergence. And a recent meta-analysis shows that traditional psychobehavioral frameworks do not work for over half of people with eating disorders in the long term, and that included neurotypicals. We'll go into more depth in that in future slides or future modules. Current eating disorder treatment and much of the research is weight focused and contains a lot of fat phobic biases and is designed with underweight anorexic clients in mind. Both outpatient and inpatient eating disorder treatments often require weekly or bi-weekly weighing throughout the treatment, where the individual's weight is graphed as a form of exposure therapy. The rationale for this weight exposure is to demonstrate that clients will not rapidly gain weight from increasing their intake. Unfortunately, in practice, what this looks like is I have had many of my clients told, don't worry, we won't let you get fat, or some sort of version of that. In these treatments, BMI of 20 is often the goal weight. And if clients go over this number, their meal plan can be reduced, even if the client is reporting hunger. It is still widely believed that individuals in larger bodies with eating disorders should receive renourishment, but only if the renourishment doesn't lead to weight gain. So obviously some fat phobic undertones there. I see how this is well intentioned, but unfortunately it really does reflect fat phobic sentimentality, that the worst thing in the world is to be fat. That is, we can't be too skinny, but we don't want our clients being too fat either. And anecdotally, I have seen this type of behavioral exposure in CBTE, for example, increase preoccupation. And I've seen clients in FBT, so family-based therapy, who are hungry, being told to resist eating until it is snack time because their BMI, in the context of their BMI, has gone above 20. So they no longer should listen to their hunger if it's not the sort of hunger at the right times. And clients in weight stigmatized bodies who are required to stand on scales and plot their weights are acutely aware that their weight is at the wrong end of the scale. Current eating disorder treatment also requires detailed food tracking. This can be unrealistic for ADHDers or for clients with complex physical health issues. It can just simply use too many spoons. And it is based on clients without complex co-occurring difficulties or challenges. So clients with complex co-occurring issues such as complex PTSD, psychosis, acute suicidality tend to be excluded from research. Eating disorder activists argue that eating disorder treatments appear to be designed with thin, white, neurotypical middle class clients in mind. And this is really unfortunate given that so few people with eating disorders are actually underweight, and the fact that the health consequences of atypical anorexia nervosa. So atypical anorexia nervosa is used for clients with anorexia who aren't below a BMI of 17. So the health consequences for those individuals are on par for those with anorexia nervosa, and that eating disorders target all groups of people, including marginalized groups or non-white individuals or non-females. Current eating disorder treatment is based on neurotypical individuals and what would help them, and tends to be quite formulaic and non-intersectional. So neurodivergent lived experience activists have been very vocal about the harm that eating disorder treatment has caused them, and this is backed by research too. The most popular eating disorder therapies are heavily manualized and structured and require a focus on the eating disorder throughout. So if you have a client that is suicidal or experiencing PTSD flashbacks, there really isn't the scope to include crisis management strategies or trauma therapy in these evidence-based approaches. And anecdotally, I've had numerous clients told that if they do not commit to weekly or twice weekly sessions, they will not recover. So essentially, if you are not wealthy and you don't have that, you can't financially access these treatments, you will not recover. Current eating disorder treatment also posits clients as manipulative and dishonest. So it is completely true that dishonesty can be part of eating disorder pathology, and we'll talk about how to navigate that in Module 10. But I have seen this mistrust then extended to the client's emotions and experiences, that they're being dishonest when they're presenting distressed, for example, which is very unfortunate. And finally, current eating disorder treatment results in iatrogenic harm. So this is harm caused by health professionals or by medical treatment. And I've seen this in my clinical work, and this is also reflected in the research. Inpatient eating disorder treatment in any other context would be a human rights violation. Right, so those are the references from the previous slides. If not what we currently have, then what? So I have some initial ideas on where we should be heading. So the first thing I think that really needs to shift is abolishing the therapist as expert mindset. Clinicians do have experience, but it may not apply to the client in front of them. Clients are the expert on their lived experience. Therapy should be collaborative, that is, two people working together. And in practice, this looks like avoiding assumptions based on clinical experience or your education as a health practitioner. In practice, this looks like asking a lot of questions. So yes, providing psychoeducation, but doing a lot of listening, because a lot of our psychoeducation is generalized and may not be appropriate to that particular client or may not be a fit. When I ask questions, many of my clients look at me as though I have asked in a ridiculous question or say, aren't you meant to know this? You're an eating disorder psychologist. So for example, one of the questions I might ask is, do you find feeling full uncomfortable? Which clients might find the answer to be very obvious. But one thing I have learned after all these years is to never assume. While there is definitely significant overlap, every person is different, therefore every eating disorder is different. And the only way we can really deliver appropriate intervention is to really get to know the client in front of us. And we need to keep asking questions because eating disorders change over time. They are shapeshifters. So we can't assume that we've gotten our head around a particular client's eating disorder and not keep doing the work to understand it. A second thought is that we need to stop pushing one-size-fits-all treatment. So in practice, this looks like presenting clients with a range of treatment options, including non-exposure therapy options, discussing the pros and cons of each, and letting the client decide what is the best fit for them. Clinicians should be offering a range of treatment options and adapting the treatment to the individual rather than forcing the individual to adapt to the treatment. We also don't want to be telling clients anything along the lines of, this is the only treatment that will help you. Evidence-based therapy is important, but pushing the therapy with the strongest evidence base is not relevant or appropriate if the research it is done on is based on clients that are not like your client. So for example, research based on wealthy, neurotypical, underweight clients with no significant occurring issues, when we have a multiply neurodivergent client in front of us that is experiencing marginalization in a number of ways. And one other thought is, I think that we need to be firmly weight neutral and weight inclusive. So clinicians should work to reflect on their own internalized weight stigma. So you might benefit from reading books on this matter or by following fat activists on social media, especially those with eating disorder lived experience. Clinicians should be supportive of renourishment in all clients, including clients in weight stigmatized bodies who may need to gain weight as part of their recovery. Clinicians should be mindful of the potential harm caused by using certain eating disorder diagnostic labels, such as atypical anorexia, essentially someone with all the markers of a restrictive eating disorder but isn't skinny enough. I've written an article on this, which is shown there in the picture. As an eating disorder psychologist, I reject the harmful atypical anorexia nervosa diagnosis, and that is linked. There's the link to that below. Clinicians should be mindful of and prepared to compassionately inform clients who may have their own internalized fat phobia of the intersection between weight stigma and eating disorders. Common gaps of knowledge include clients in weight stigmatized bodies may have a primarily restrictive eating disorder. Starvation syndrome symptoms can occur in any weight, not just clients that are underweight. Weight is largely determined by genetics. Eating disorders can be deadly at all weights. And menstruation in clients that are AFAB, so assigned female at birth, is not a reliable indicator of health, etc. Clinicians should not be using any one measure as a reliable indicator of health, especially weight, but also bloods, for example, as individuals with severe and enduring eating disorders tend to have stable bloods and sometimes even a stable weight as their body has adapted to chronic restriction, chronic starvation. Clinicians should stop using BMI as a marker of health. While being underweight often means being malnourished, this does not mean that not underweight equals nourished or not eating disorder or recovered. Clinicians should be mindful of the potential harm of requiring clients to be weighed regularly. My preference is using non-weight based health indicators and only using weight in cases of significantly low weight or rapid and extreme weight loss. And even in these cases, my preference is for the weight to be blind, to be done by a health at every size or weight neutral GP, and not to be the determiner and the focus of treatment. And finally, at the very least, we should do no harm. We should be listening to our clients at every step of the way. We need to empower clients to speak up regarding what they find is helpful and harmful for them. And we really need to let go of the mindset that the eating disorder is the ultimate harm or danger. Our clients might be facing many potential problems, including suicidality. That is part of why eating disorders are so lethal. It's not just clients with eating disorders dying from the eating disorder, but from dying by killing themselves. Other harms they can face is stigma from being in a marginalized group, stigma from other struggles such as self-harm, rejection sensitivity from years of being misunderstood, etc. We cannot use a situation being life or death as an excuse for poor quality treatment. So these recommendations have come primarily from my clinical experience, so listening to my clients and what they're reporting is helpful and unhelpful, but also through listening to lived experience peers and lived experience activists. I will see you back next week for Module 2, looking at safety.